This module covers inflammation and wound healing. The patho section of this module really should be a review of the inflammatory response and infection. There's a really good video in your step 0 that talks about this kind of patho, so make sure to review that and know the vascular and cellular responses. Just a reminder that there is both local and systemic responses to inflammation. I think this is also a good point to bring up that inflammation does not always mean infection, but infection always has inflammation. The local response to inflammation, usually redness, heat and warmth, pain, swelling, and possible loss of function. This is just a really good visual, a way to remember the manifestations, the local ones. So the heat is the fire. The redness, he's blushing because his clothes fell down. Swelling, has a swollen belly. Pain, his foot got hit by his neighbor's arm. And loss of function, losing his limbs. Now, when it comes to the systemic response to inflammation, this is one that we're more worried about. What you can have is what's called a shift to the left. So this is an increase in white blood cell count due to neutrophils in relation to bacteria. You could also have malaise, nausea, anorexia, increased pulse, and increased respiratory rate and fever. This is basically the first steps to going towards what we call sepsis. Really acute infection, there's a need for antibiotics. Systemic response to inflammation also includes fevers. Fevers are a big one. Sometimes they have chills and shivering. Their body is hot, yes, yet they really are asking for warm blankets because they are just so cold, but you don't want to give them the warm blankets because it's going to drive their temperature up. We don't always want to lower a patient's body temperature. Sometimes a low-grade fever is good. It's the body's natural way to fight the virus. So usually mild to moderate fevers, like low grade 99 to 101, usually does little or no harm and poses no great discomfort, and may actually be beneficial. The only time we really want to give antipyretics during those fevers is if they have like the aches, the chills, feeling cold, and they're just kind of miserable. If the patient's getting like antibiotics, we want to continue to monitor that temperature to make sure it doesn't continue to trend upwards, because the antibiotics really should be helping lower that temperature. Usually antipyretics are more beneficial for patients that are very old, very young, in severe discomfort, or have other severe medical problems. High fevers, those above 102, 103, especially 104, those can cause febrile seizures, especially in our younger population, and can cause damage to cells and even brain cells at higher temperatures above 106. So that's where it really can cause some real big brain damage. So the goal, really, don't treat the fever unless it gets too high, unless the patient's miserable. Health promotion. So prevention is always best. Remember that throughout nursing. We want to prevent things from happening first. So we want to prevent infection. We want to prevent trauma and surgeries that are unnecessary in contact with potential harmful agents. But that's not always possible. So aggressive efforts to decrease inflammation and infection are necessary. So adequate nutrition is essential to promote healing when injury occurs. This includes increasing fluid intake and additional calories, especially if they have a fever. If they have a fever, they're losing more water, and so they need to intake more water. And sometimes, especially in our younger population, older population, they don't want to have that extra intake, so sometimes they do need some IV fluids. Early recognition of inflammation, we really want to see the first results and immediately treat. So this is a big section to remember. This is the collaboration of knowing RICE is what it's called. Rest, ice, compression, elevation. It's really important and a key concept in treating soft tissue injuries and related inflammation. So rest really helps the body use nutrients and oxygen for the healing process. Ice promotes vasoconstriction and decreases swelling, pain, and just kind of inflammation to that area. In general, it says it's like applied every 15-20 minutes for every 2 to 3 hours for the first 24 to 48 hours. We do not want to expose them to too much cold because that can lead to tissue damage. So you don't want to have direct ice on skin kind of thing for long periods of time, especially. Usually 24 to 48 hours afterwards, that's when we can start using heat. But really you want to start with ice. One population to be very careful with when using ice is the diabetics and neuropathy, because they can't feel if they're having tissue injury. So if the ice slips off and is directly on the skin, they're not going to be able to feel that, so they're not going to be able to feel the injury. Compression serves to kind of counter the vasodilation effects and development of edema, so usually we ACE wrap that kind of area. And then elevation above the level of the heart is big. This decreases edema to the inflammatory site and just kind of helps with decreasing pain associated with like blood going directly to that site. So usually after inflammation is the process of healing. So usually we see two processes: regeneration, which is replacement of lost cells and tissues with cells of the same type. And then you could also have repair, which usually is a result by the loss of replaced by connective tissue. It's more usually the common type, and it does usually have some kind of scar formation. So there is three major types of wound healing we think of: primary, secondary, and tertiary intention. So primary intention, I think of a straight surgical incision, paper cuts, these easy, well-defined edges that just come together perfectly where we can suture and staple them. Secondary intention is usually larger, wider, more tissue involved. It involves generating granulation tissue to close the wound, so usually causes a scar. So if you think, oh, those wounds don't come together, there's this middle gap, and the scar tissue needs to come together to really close that wound. These wounds can occur from trauma, ulceration, infection, large amounts of exudates, or just wounds with like irregular margins. And then tertiary intentions, these are usually the big, large wounds, often contaminated due to infection. Sometimes there's a delayed closure site due to the size, the loss of tissue. There's no way you can have enough skin to close it. I always think of big stage 3, stage 4 or ulcers where there's not enough skin to kind of close that site. Sometimes it can be delayed primary intention. So they will open up in surgery a wound, say an abscess, and they don't want to close that wound because there's infection and contamination in the wound that needs to drain out first. So they will go back after the infection is controlled to close the wound. Another big piece of wound classification that you should look at is the causes and the depth of tissue involved. I think this is very important to look at: surgical versus non-surgical, acute versus chronic, and then looking at superficial, partial thickness, and full thickness. What are the differences? What do they look like? Especially knowing their depth of tissue, where they go into. Color is a big thing when you're looking at wounds to know kind of what's going on in general. So if you look at a wound and it's red, it's generally healthy tissue. Yellow, usually not so healthy. Purulent drainage or slough or different things coming out of the wounds. This can definitely cause a thought of, is there an infection in there? Black usually means necrotic and dead tissue. There's no way for that to heal. It's not coming back. So usually it has to be removed before healing can even begin. Sometimes wounds have multiple colors, right? The middle of the wound, black, or the edges of the wound, black. Some of it's yellow, some of it's red. So you usually classify it according to the least desirable color present. If black is there, you're going to call it black. If there's yellow, you're going to call it yellow. Those kind of ideas. So make sure to spend time looking at the complications of healing. Really, the shape and the location of the wound determines how well that wound will heal. So look at some of the complications, including adhesions, evisceration, dehiscing, fistula formation, infection, hemorrhage, and scarring. So look at those, know what those look like. I will warn you, in the rest of the slides, there are pictures of wounds, so be aware when you're moving forward. Maybe don't be eating food. This is important to know what normal healing looks like, because normal healing will have inflammation and pain to the area. That is normal because that is the normal healing process. Just remember, inflammation does not always mean infection. So normal healing, you could see, like in this top picture, this is probably the day after surgery, or that they got these sutures. See how it's raised, it's kind of puffy. There's a little bit of redness right there. And then you can see how it ends up healing with the scar formation. That can be normal healing. It's important to measure a wound size and to continue to measure wound sizes to see if it's getting bigger, if it's healing. So you can see they make these little outlines so that you can literally draw the shape of the wound on, and you can measure it that way. There's this idea of the clock face method. So the head of the body is always 12, the feet is always 6. And so if you were talking about a specific wound, you will talk about at 1 o'clock there's this, or 3 o'clock there is this. So this is a good idea of a sacral wound, right? This is definitely tertiary, right? So 12 o'clock you can see is pointing up towards the spine, towards their head, 6 towards the base. So if you have what's called tunneling, which is something that happens in some wounds where the wound will literally tunnel underneath the skin where you can't see it. So let's say you are measuring with a Q-tip, such as this, the depth of the wound, and all of a sudden you notice tunneling. You can say at 10 o'clock there is 3 inches of tunneling, and what you'll do is you'll take your little Q-tip and you will measure how far into the wound it goes, and then you'll pull it out and you can measure from that point. This shows a couple of complications. The dehiscing on the far left, this is where the wound divides and opens. Infection, you can see it's nice and red in that second picture. The third and the fourth are sometimes hard for people to kind of know the difference between. The third one is hypertrophic scarring, so too much collagen production, where the fourth one is keloid scarring, which is overabundance of scar tissue that protrudes past the wound edges. So usually see the third one stands within the wound, and the fourth one moves outside of those wound margins. Dehiscing wounds. This is usually a divided wound. So a patient, let's say with an abdominal injury, all of a sudden sneezes. I've seen that a couple times where they sneeze and their wound just opens up. This one is not very good, right? This is an emergency, but evisceration is worse because the intestines actually exit the wound. So if you see either of these situations, it is an emergency, needs to be dealt with promptly. Usually what they say now is to cover it with a wet dressing, right? You don't want to put dry on intestines because when they try to pull that dressing off and it kind of peels off. So you want to put wet dressing onto that area. This is just another good visual of dehiscing versus evisceration. So things that delay wound healing. This is important to know. Nutrition is a big one. They need proteins, they need fats, they need carbs. So if they are not getting the nutritional needs that are required to heal these wounds, there's going to be a delay in wound healing. Corticosteroid use impairs phagocytosis of white blood cell counts and delay wound healing. Decreased blood supply inhibits inflammatory response. Infection increases tissue destruction. Actually, another big one is smoking. Nicotine impedes blood flow to tissue because it is a vasoconstrictor. Advanced age, usually the elderly population have slow wound healing. Obesity, there's a decreased blood supply to fatty tissues in those skin folds. So when these patients, the obese patients, get these massive pressure ulcers from laying too long or something like that, then there is actually a decreased blood supply to that tissue, so it's not going to heal as fast. And then the big one, diabetes, hyperglycemia, because it impairs phagocytosis and it decreases O2 supply due to vascular disease. So especially if their diabetes is poorly controlled, they're going to have a decreased wound healing. And then anemia, decreased red blood cells means decreased oxygen at the tissue injury level. So another big reminder, diabetes, slow wound healing. If there's a wound that you're like, man, they've had that for a really long time, or sometimes it's on their feet and they can't feel it, this is a sign of diabetes. So purpose of wound management, cleaning a wound to remove dirt and debris from the wound bed, treating infection to prepare for more wound healing, and protecting clean wounds from trauma. So wound management, the type, extent, and characteristic of wound determines the wound management. So dressings, it's really going to depend on the wound. Are we going to use wet? Are we going to use hydrocolloid? Dry, non-adherent, completely depends on the type of wounds. Sometimes for closure, instead of sutures or staples, we might use adhesive strips or Dermabond instead of sutures. And then wound vacs, sometimes they will need, I'll show pictures later, but wound vacs to close that large wound. Sometimes they can use hyperbaric O2 treatments, which is literally like 100% oxygen for high levels of time. And this is supposed to accelerate granulation tissue formation. And then sometimes they need debridement. There's different kinds of debridement of wounds that might be necessary. Sometimes they have a chemical debridement or a surgical where they use a sharp tool to debride. There's a couple different types of debridement that they can use. So sometimes with primary intention wounds, they close up, they suture this beautiful wound together, but they know that there's going to be drainage underneath. So what they will do is put in different drainage devices to help drain the fluid underneath and help with that inflammation of that area. Usually the big one we see is Jackson Pratt drainage device, also known as a JP drain. It's a suction device, so it's actually a little flexible bulb. You can see that when you squeeze it, it provides suction basically to pull fluid out from underneath the wound. And sometimes they can say a half compressed bulb or a fully compressed bulb. Sometimes they don't want the bulb compressed depending on the different kinds of drainage they're seeing from the wound. So as a nurse, it's important to look at that drainage, know how much is too much drainage. If you see large amounts of drainage pouring out of this wound, that is a concern. And then knowing what happened on the shift before you and giving to the next shift, hey, this is how much fluid came out. This is what it looked like. This is what you should be aware of. So important things to know with JP drains. Secondary intention wounds, usually you see that red wound. There's granulation in the area, so protect the wound. Gentle cleaning. We don't want to get rid of that new granulation tissue that is forming. So naturally, moist wounds are the best wounds. We do not want a wound to dry out. Dryness is an enemy of wound healing. So airing out a wound is actually a huge mistake. Wounds need a moist environment to heal. Dressing material that keeps the wound surface clean and slightly moist is the best to promote epithelialization. So sometimes Tegaderm or occlusive dressings that are permeable to oxygen might be good, such as Tegaderm or something like that, but you really want moisture still in that site. So yellow wounds, you really want a dressing that absorbs the exudate and cleans the wound's surface. So usually you see this in our hydrocolloid dressings, such as Duoderm, usually designed to be left in place for up to 7 days or until leakage occurs around the dressing. What that's going to do is it nicely absorbs that exudate while keeping the wound nice and clean. But what you don't want to do is pull off that dressing too early, because then again, that pulls out the granulations that is happening and the healing that's already happening. And then black wounds. Usually you got to get rid of the black wound first. So debriding is the first method. Usually it depends on the amount of debris, the condition of the wound, how much eschar tissue there is. So there could be some different options there. So this is showing two different dressings, the hydrocolloid on the left, which needs to be left for up to 7 days, and the Tegaderm Opsite on the right. Another big dressing that we use is non-adherent dressing. This is dressing that's going to sit against the skin. It's going to absorb whatever, but it's not going to stick to the wounds. Again, we don't want things to stick to wounds so that when you pull it off, it causes more damage. Tertiary intention. This is a good example of a nice big open ulcer wound. they use what's called negative pressure or wound vac therapy. What you do is really there's two options: wound vacs or skin grafts. Usually they will not do a skin graft until it is completely healed of any infection. So a wound vac is good for that. A wound vac will attach into that whole area and it'll suck out any kind of exudate, infection, those kind of things, and help that wound slowly close. So as you can see here, A is where the wound, B is the actual wound vac. So the black foam actually sits in the wound bed, and then it is connected to a suction device that helps suck out different exudate and allows for that slow closure of the wound. Nutrition therapy is very important for wound healing. They need a diet high in protein, carbs, and vitamin with moderate fat, especially in patients such as Crohn's disease patients or GI surgery, liver disease, anyone that's kind of deficient or has high energy demands. And then diabetes is always one to think of. Infection prevention. Do not touch recently injured areas. Remember, not all wounds are infected, so we need to keep the environment free from any kind of possible contaminated items. Antibiotics may be given prophylactically from the beginning. We can do cultures of wounds. This is something that is within the nursing scope of practice. So you take a little swab, you swab from the middle of the wound, and it really should be done before the first dose of antibiotic is ever given. We're really trying to get up that wound exudate, and that's where we get the specimen from. Sometimes there's nothing that's really coming from those wounds, so we try to get a little bit, but sometimes the cultures need to be obtained by needle aspiration or tissue culture. Those are above our nursing practice and usually is done in a surgery setting or by a provider. Patient teaching. Teaching them signs and symptoms of infection after surgery is very important. They are getting a lot of discharge information after surgery, but that is a priority. What should they be looking out for? What should they call for? Things like that. They should note changes in wound color or amount of drainage, and then just providing overall medication. What are the adverse effects that they should be looking for? How long should they take antibiotics for? Those kind of things are very important to prevent any kind of infection, reinfection, or drug-resistant infections as well. Overall, wounds can be very overwhelming. We have amazing wound nurses out in the world that specifically do these kind of dressing changes and know these kind of issues. So your big idea is to know the overall, how to assess wounds, how to treat a wound and then treat a wound emergency, and educating patients is always a big one.